Thank you, Philip and Scott and to Sages for the invitation. So I was tasked with talking about robotic component separation in the acute care setting. These are my disclosures, but one more disclosure that I have is that I'm a trauma and acute care surgeon, and I do a lot of complex abdominal reconstruction, but to be completely honest, I typically do not do them in the same setting. And I'm going to hopefully be able to elucidate as to why that is in this next 10 minutes. So we've heard some great talks, right? We've heard the techniques about complex abdominal reconstruction, whether it be anterior or posterior releases. We know what the indications are. These are complex hernias. Conrad showed the Carbonell rule with respect to the rectus width to the defect width ratio in order to determine if a posterior release may be needed. Our goals always are to restore the linea alba, and then of course we want to be able to place a large piece of mesh to completely reinforce the visceral sac. These are great for atypical hernias, as we saw, getting up to the central tendon, well down in the space of Resius, very lateral hernias if they're peristomal hernias or the such. And the principles are the same, right? Our goals are to be able to achieve defect closure, minimize fixation. This is what we're doing more now with the minimally invasive approaches to complex ab wall. We want to place an uncoated mesh and do MIS approach if possible. But taking each of those into account, think about the emergent setting. If we're going to achieve defect closure, we want to hopefully have the best tissue viability, the best tissue integrity. We want to be able to place an uncoated mesh, right? And so we're placing a synthetic mesh most commonly in these settings and in the extraperitoneal space. But our goal really is to be able to do the best for our patients. So again, we've heard about the anterior component separation. There's the rectus abdominis release, or the traditional reef stopa, and then the transversus abdominis release, all of which can be done in a minimally invasive fashion. However, for the emergency patient, these patients are not optimized, right? Oftentimes these patients are coming in, they're potentially elderly, they're obese, they have a number of medical comorbidities, and depending on the reason why they're coming in emergently, they may be hemodynamically unstable or even septic, and there may be gross contamination. We spend so much time when we're talking about complex abdominal reconstruction at the various hernia meetings and in these different sessions on really focusing on pre-op optimization. We can't do that in the emergency setting. So what does the literature show? This was Huckabee and colleagues looked at, they wanted to be able to see what were the outcomes and the implications for addressing these emergent hernias for acute incisional hernias and incarcerated hernias in the emergent setting. We know at baseline that doing a laparotomy gives approximately a 20% chance or incidence of developing an incisional hernia, and that might be in the best of settings. So this study looked specifically at incarcerated hernias in the emergent setting, and what they showed using the ACS risk calculator was that with increasing age and with the need for bowel resection this was associated with an increase in mortality. Looking specifically at mortality, after emergent repair, it showed 23% versus less than 1% increased risk of mortality doing this in the emergent setting compared to the elective setting. And again, this is complex abdominal reconstruction in the emergent setting. And this was for all ages. When adjusted for age, less than 60 to those over 80, if this was done electively, they had very similar outcomes being with respect to mortality as less than 1%, but it got much higher in the emergent setting. Let's take into account frailty index scores. So again, there's a specific frailty index for complex abdominal reconstruction. If your patients are coming in the emergent fashion, they're going to have probably a higher frailty index. A large NISQIP database of over 70,000 patients looked specifically at this, and the goal was to look at morbidity, grade 4 complications, and mortality with respect to incisional hernia repair and complex abdominal reconstruction. And those patients with a higher modified frailty index, that portended a 7.7 likelihood of all-cause complications, 35 times likelihood of severe complications, almost 4% likelihood of surgical site complications, and 62 times likelihood of death. So, again, you need to take this into account when we're talking about complex abdominal wall hernia repair, because it's not just the outcomes of the hernia, but it's also the outcomes for the patient. So what is our goal as hernia surgeons and/or acute care surgeons? First thing we need to do is manage the acute problem. Oftentimes what we'll do in this setting is we're going to stage the repair. I want to deal with the emergent problem that brought the patient into the hospital and not necessarily go on to repair their complex hernia. Our goal is to reduce complications and, again, mitigate morbidity and mortality and come back to fight another day. If if, as a trauma acute care surgeon, we're often faced with the open abdomen, whether this is a diverticular disaster or this is let's say a motor vehicle accident or what have you, but these patients often come in with contamination. They're not optimized, as we talked about, so we have a number of options when we're dealt with the open abdomen. Obviously, this is not going to come together primarily. In my opinion, this is not the right patient to go ahead and do a transversus abdominis release, right? So we have some options. We can have skin closure. Our goal is to cover the viscera and, again, be able to come back to deal with this complex hernia at another time. You can bridge it. You can use vicryl mesh, as we've seen. You can use a biologic or a bioresorbable mesh. But the key is not to burn bridges with doing a complex ab wall reconstruction during that current admission, because the likelihood of that patient having a complication and or potentially a recurrence, which is what we're trying to avoid with these big ab wall reconstructions, is going to be much higher. This was a Danish hernia registry study that looked at just over 1,000 patients. 882 were elective, comparing 168 emergent. Same thing they showed. There was an increased risk of complications with emergent repair when mesh was placed in the retromuscular space. So again, this was complex abdominal wall reconstruction, whether it was with a reef stopa repair or a transversus abdominis release, but the mesh was kept in the retromuscular space. Comparing emergent to elective, there was a higher risk of all complications, readmissions, length of stay, and reoperations. Retromuscular versus onlay was higher in the emergent ventral hernia repair setting, and when you combine the two together, there was a 10.1 odds ratio of increased risk of all of those things when compared to elective repair. So again, emergent ventral hernia repair from this study concluded that it probably should be avoided, especially placing the mesh in the retromuscular space and doing your ab wall reconstruction. So when we think about emergent component separation, the way that I look at these patients is, why are they coming in? What is the reason for the emergent repair? If they're coming in with a bowel obstruction, obviously we're going to look to see, are they incarcerated or strangulated? If they're incarcerated and you can have reduction of that contents and there's really no other reason they're not that sick, then absolutely I think it's reasonable to go on and do a definitive repair, looking at an ETEP approach to a patient that came in with a complete bowel obstruction but complete bowel viability, and I think that was appropriate in this setting. If you don't have to do a bowel resection, then you can go on to do your MIS release, whether it's a reef stopa or a TAR. But if there is bowel resection, I don't think you need to go on to do your definitive repair. I think that the risk of infection, the risk of recurrence is too high. Even if there's a chance that that's not going to happen, and we do know that the meshes that we use now, the macroporous medium weight polypropylene meshes, can withstand a lot. Even in the setting of some infection, we can often get those patients through without having to remove the mesh. But I do think that personally it's not worth the risk to go on to do a complex reconstruction in this acute setting. So, our goal as hernia surgeons really is, we still don't know what the best technique is, right? We're talking about a number of techniques, we're talking about the different meshes, and we still don't have a very low recurrence rate. Actually, it's quite acceptable, but we're still, all of us in the room will probably have some different opinion as to how to approach a lot of these hernias. And the emergency patient and the emergency hernia is a very complex problem. And when we're dealing with complex hernias and component separations, our goal is to be able to hopefully let this be the very last repair for this patient. So in the setting of contamination, the need for bowel resection, poor frailty scores, the things that we can take into account prior, I think it's important to avoid formal abdominal wall reconstruction. And even though robotics definitely has allowed us to push the envelope with a lot of these techniques, and we're able to do more minimally invasive complex ab wall reconstruction, I think that it's important not to burn bridges in the emergent patient. So thank you.